Good morning and welcome. My name is Leslie Chambers. I'm the president and CEO of the American Parkinson Disease Association. And on behalf of everybody at APDA, I want to thank you for joining us on day 2 of the 3rd annual Midwest Parkinson's Congress, which is hosted this year by the Greater St. Louis and Midwest chapters of APDA. We had an amazing day yesterday with over 1,000 participants as we learned about the latest in treatments and research from our expert scientists and clinicians, Drs. Perlmutter, Shaikh, and Gilbert. We are so grateful for their contributions to the field of Parkinson's disease and for everything that they do for APDA, so thank you so much. Today, we have another outstanding lineup of Parkinson's experts, including leading industry professionals who will be discussing the latest in cognition, deep brain stimulation, and the use of medical marijuana in the treatment of Parkinson's disease. I'd like to once again thank our over 20 sponsors who helped make the Midwest Parkinson's Congress possible. And although I can't mention them all now, I do want to give a special thank you to our champion sponsors, the James and Allison Bates Foundation and the JCA Charitable Foundation. I would also like to thank our collaborating sponsors, Acadia Pharmaceuticals, Amneal, Emerson Hermetic Motors, and Kiowa Kirin. Please take time again today to visit our sponsors' resource booths so you can learn more about how our sponsors support the Parkinson's community. And you don't have to worry when you visit the booth about missing any of our experts, as all of the sponsors' booths will have the conference broadcast live. So once again, thank you for your participation and enjoy today's Congress.
Hello and welcome to the APDA Midwest Congress. My name is Dr. Jennifer Goldman and I'm delighted to be here today. I'll be speaking about cognitive and other non-motor behaviors and how to cope with their manifestations. These are my disclosures, as you can see here in the slides, and I will talk a little bit about off-label medication uses. So these are some of the objectives for today's talk. I'll describe clinical features and concepts, as well as management related to cognitive and non-motor behavioral changes in Parkinson's. And I'll also talk about what we can consider our top 10 life hacks or coping strategies as a way to illustrate things that people living with Parkinson's and their care partners can do about these cognitive and non-motor behavior symptoms. So the first of the top 10, is to know the symptoms. And with that, I'll start by talking a little bit about some of the common cognitive and behavioral symptoms that we can see in Parkinson's, because we know that Parkinson's, while it has tremor, stiffness, slowness, or walking changes, is much more than a movement disorder. We know it can affect all these different areas and even more that are not shown on the slide that relate to cognition, mood, autonomic function, so blood pressure, bladder and bowels, behavior, sensory symptoms having to do with smell and vision and pain and musculoskeletal system and sleep. And I know you'll hear from some other talks in this series about sleep and fatigue. So we will really concentrate our efforts on these 3 areas for today's talk. So I will speak to you a bit about cognitive changes, and I'll talk about what it means to experience and our definitions for mild cognitive impairment and dementia. We'll talk about mood changes represented by depression and anxiety. And then we'll talk about some of the behavioral symptoms that are a varied bunch of behavioral manifestations such as apathy, psychosis, and impulse control disorders. And through this talk, I'll illustrate what these symptoms are and how we think about them as clinicians and researchers and how we define them to better understand them. So first and foremost, I think my first immediate takeaway message is that not everyone with Parkinson's will have cognitive or behavioral symptoms. So that is first and foremost. We know these topics can be difficult to talk about or hear about. They can be scary. Mental health topics can often be loaded with a lot of stigma or fear or concern. But it's really important that we have accurate definitions and information. And we do know that management strategies, team care, and research can make all the difference. So here you'll see the phrase, knowledge is power. So I hope through some of these educational activities in this Congress and other educational sessions that you might attend, we can empower you and give you some of the tools and resources to understand the symptoms and address them if they are present. So first, to talk about what is cognition. So cognition actually comes from the Latin root cognoscere, to know. And cognition is a very broad area. So it represents our mental actions and processes of acquiring knowledge and understanding this through our thoughts, our experiences, and our senses. So it's how we take in the world around us and process it and understand it, as well as interact with it. One thing that I'm often asked about or told is when people say they may have cognitive changes, they may say, oh, my memory's bad, or my memory's not what it used to be. But cognition includes much, much more than memory. So it is not a direct equivalent. It does not equal memory, but rather it includes many different cognitive processes that you can see here in the circles below. These include things like attention, learning and memory, working memory, a very specific type of memory, which is holding information in your head while you're doing something else. So like remembering a phone number while you're writing the list of groceries or talking to your spouse or so forth. Comprehension, language, judgment and evaluation, problem solving and decision making, and reasoning are all aspects of cognition. So here's a slide that describes some of the cognitive symptoms, some of what we call as clinicians and researchers domains, or kind of buckets that we put these cognitive symptoms into, and a number of the areas of the brain that are involved. So here you can see we might divide them into 5 different areas or cognitive domains. The first one being attention and working memory, where some of those symptoms might include trouble concentrating or difficulty keeping track of information in one's mind, as I just mentioned with the example. And this is often involves in an area of our frontal lobe, the very front part of our brain, including a very specific area called the dorsolateral prefrontal cortex, and how it connects and relates to another area kind of in the towards the back part of the brain called the parietal lobe, and an area called the basal ganglia, which we know is highly involved in Parkinson's disease and dopamine regulation. So that's one area of cognitive symptoms. Another area that can be commonly affected in Parkinson's is called executive function. And so you can think of this as perhaps the CEO, the executive of the brain, or the conductor of the brain's orchestra, putting it all together. So processing information, organizing it, planning it, initiating activities. People may experience difficulty with multitasking. They may also have trouble stopping and starting activities. And this is all part of executive function. And it involves a very front part of our brain called the prefrontal cortex and basal ganglia. Language is another cognitive domain. And this sometimes we can see in Parkinson's in a number of different ways. Probably the most common, people may say they have difficulty finding the words they want to say. It might be kind of on the tip of their tongue, but it's hard to get it out or it's slower to process it. They may have reduced fluency of speech, so shorter sentences, might be hard to find the word they want to say. And this involves a number of regions in the brain, but particularly the temporal lobe. Memory, and I mentioned before, memory has a number of different types. One involves learning, and so how we learn, get information, encode it into our brain, remember it, and are able to retrieve it. So how do we recall facts or events? That's one type of memory called declarative memory. There's also a memory of how we do things. So how one rides a bicycle or remembers a certain activity, and that's called procedural memory. And that type of memory often involves the basal ganglia. Lastly, there's visual spatial function, and people may experience difficulty navigating the world around them, such as sense of direction or getting turned around, or perhaps even lost in a new environment. And we talk about how this might affect daily activities or driving. And we may test this in the clinic by having people draw objects as well. And this involves some of the back regions of the brain called the parietal and occipital lobes. So as you can see, cognition can be a very complex area. Cognitive changes can occur in Parkinson's, but as I said, first and foremost, I will talk about some things that some people in their Parkinson's journey may never ever experience. So it's important always to keep that in mind. The frequency estimates of cognitive changes in the literature really vary quite a bit. We think of mild changes, which could be slowing in thinking or slower processing, kind of like slower movements. In more recent years, we've defined this as an entity called mild cognitive impairment, such as people may have mild changes, but they don't necessarily affect their day-to-day. They might not affect their work or their hobbies or their independence and activities of daily living. And in some studies, this could occur in about 20 to 50% of patients. These mild deficits might even be present at the time of diagnosis or in early stages, and they may relate to some of the underpinnings of Parkinson's, as well as the low dopaminergic state, so having a loss of dopamine. When people have more severe cognitive changes, and they affect more than one of those domains that I mentioned, to the point that they impact everyday function, such as difficulty with work or finances or cooking or driving or other activities, we call that a dementia. About 40% of people with Parkinson's, depending on the studies, may experience a dementia syndrome. This is more common when people have Parkinson's for more and more years, so with more advanced disease. But again, and I really mention this to drive this point home, that it's very important to talk about these symptoms and have education and awareness and know what therapies are available, but really that not every person with Parkinson's will develop cognitive impairment or dementia or really any of the behavioral symptoms I might mention today. So I just want to turn, we're going to switch gears and go through some of these symptoms as a broad overview, but let's talk about depression. So depression is a mood symptom, and it can be quite common. Its frequency on average in Parkinson's is about 40%, but the estimates vary quite a bit in the literature. We've now recognized that depression and anxiety, which I'll talk about in a moment, can even be a manifestation of Parkinson's long before someone has a tremor or slowness or stiffness, those motor symptoms that we use to define Parkinson's. And so we think it can be part of this premotor or prodromal phase of Parkinson's related to changes already going on in the brain, a particular area called the brainstem, and changes in neurochemicals such as serotonin or norepinephrine and even dopamine. We know that depression can have this intrinsic relationship to the neurobiology of Parkinson's, but it also can occur as a reaction to many elements, such as getting the new diagnosis or changes in function or changes over time. So it's important for us to understand all those elements. The common symptoms that we see in people experiencing depression include sadness, sometimes decreased interest, or we call that anhedonia, and anxiety. Depression and Parkinson's can often be what we call subsyndromal, meaning we know it's present, but it might not meet the threshold of some of the criteria that are used in the psychiatric literature to define depression. Now, depression can also have what we call motor, somatic, or body and cognitive components. And it's important to recognize those because some of those can go hand in hand with Parkinson's symptoms themselves, such that someone might have reduced facial expression because they're not smiling as much. Or we can also see that in Parkinson's itself. People can have changes in sleep, such as too much sleep, too little sleep, changes in their appetite in both directions, as well as slower responses. And sometimes that can overlap with symptoms related to Parkinson's itself. Now, anxiety is another mood symptom associated with Parkinson's, and it too can be common, but it also can be very under-recognized. And I think one of the take-homes from us talking about these cognitive and non-motor behavior symptoms is people don't necessarily always ask. So it's important to also give people with Parkinson's and their care partners tools to bring them up to the clinician, to your healthcare provider, that these symptoms might be occurring. So anxiety's frequency is about 5 to 40% in the literature, and it kind of depends on how that studies are conducted and who they assessed and how they assessed them. But it's been thought that about a third of people with Parkinson's might have 2 or more anxiety disorders that we define in these contexts as listed below. So anxiety can occur as part of depression. It can also be part of something called generalized anxiety disorder, where people may have excessive worry or nervousness or tension. It can be part of panic disorder. It can be part of phobias, such as fear of going outside or being in social environments. And anxiety can also be part of the obsessive compulsive disorder spectrum. Of these listed here, the 2 that are most commonly found in Parkinson's include generalized anxiety disorders and phobias. And we know that anxiety sometimes can have this vicious cycle approach with tremor or Parkinson's symptoms, such that any sort of excitement, good excitement, cheering, or anxiety can increase tremor. But we also know that when people are anxious, they might have more tremor, or they might, have concerns about situational anxiety, such as crossing the street or worrying about freezing or having their medicines on time. So we recognize all of those too. Anxiety also has a special place in the Parkinson's symptoms and management because it can occur in a situation called non-motor fluctuations, particularly in the off state. So we're much more likely perhaps to ask about wearing off in the motor context. If someone's medicines are not lasting from dose to dose, they might notice more slowness or more trouble walking or more tremor. But similarly, people can actually have non-motor fluctuations, such as before their next dose, they might be more anxious. They might even feel like they're going to have a panic attack and have shortness of breath or sweating or palpitations. They might even feel a little bit more depressed. And that has to do with the cycle of dopamine and the levels in the blood and getting up into the brain that vary with these fluctuations. So very important to recognize those. So as we go through some of these symptoms, I'm going to move into the behavioral symptoms now. And I'm going to start with apathy. So apathy is defined technically as a primary loss of motivation. Sometimes people will say, it's their get up and go, got up and left. But apathy has an intersection with both behavior, cognitive, and mood. It actually can be quite common, with estimates of its frequency from about 15 to 70%. Interestingly, apathy can overlap with depression, so loss of interest, loss of motivation, but it can often be distinct. So it's helpful to try to tease them out as the best that we can to differentiate depression from apathy. Apathy can be associated with decreased functional independence, so not doing activities, reduced initiation or participation in activities. And this is something often as a clinician, we hear more from the care partner, sometimes more from the spouse of the person living with Parkinson's, because it might be more troublesome. And this is where it's so important to include both parties and the whole team to address some of the psychosocial aspects or resultant factors such as from apathy or other behavioral symptoms, because we know this can affect the quality of life and relationships of people. The next behavioral symptom that I would talk about is psychosis. And psychosis really represents a broad spectrum. So it includes several different symptoms that fall under this umbrella called psychosis. They include illusions, which are misperceptions. So looking at something, but something's really there, but it looks like something else. So looking at perhaps a tree and it looks like a lamppost, or four legs of a chair and it looks like a dog, or different patterns. This is distinct from hallucinations, where someone might see something, but there's not really anything there. Hallucinations tend to be visual, but they can occur in other sensory modalities that I'll talk about in a moment. But often they're described as seeing something out of the corner of one's eye. It's very quick, lasting only seconds, might have movement, animals, small children. And sometimes people can keep insight, so they'll know it's not real, or they can turn their attention to something else and recognize that what they were seeing wasn't really there. The third part of psychosis is something called delusions, which are far less common, maybe more common in, when there's also cognitive impairment or dementia. And these are false beliefs. So thinking something's really happening when it's really not. They tend to include thoughts of paranoia or suspiciousness or infidelity as well. Now we know that psychosis can occur in Parkinson's. There are a number of contributors, some of which could be medications, older age, longer Parkinson's duration, and the presence of difficulties with cognition and sleep. So it may have a multifactorial etiology. As I said before, visual hallucinations tend to be the most common that we see or hear about, but sometimes people may experience these in the auditory system, like hearing music or hearing voices, smelling things that aren't necessarily there. So it's important for clinicians to ask about all these different circumstances. Again, not everyone will experience these situations or behaviors. And I do want to mention that psychosis in Parkinson's is quite different from psychosis, in case you hear about it, in psychiatric conditions such as schizophrenia, or even in depression with psychotic features. So they have very different symptoms and very different contexts. The last behavioral symptom that I want to touch upon is something called impulse control disorders. And this also represents a range of behaviors that include the four most common ones that we see, but there may be others. And these are pathologic gambling, compulsive shopping, hypersexuality, or increased libido and sex drive, and binge eating. They're less common, but frequencies have ranged to up to about 10%. What they share is that they're repetitive and reward-seeking behaviors. What they link to Parkinson's about is because they're linked to dopamine. So in a sense, when we treat people with Parkinson's with dopaminergic medicines, sometimes that dopamine increases the drive to the reward system too much, and it produces impulse control behaviors that really are often driven by the medications that we use to treat the motor and other symptoms. This can be common in medicines called dopamine agonists, but also other Parkinson's dopamine medicines. However, there may be some risk factors, such that people may have a prior history of psychiatric disorders or addiction. They may have some cognitive changes and have impaired decision-making that help, contribute to the presence of these impulse control disorders. Much of the time when someone stops the drug or lowers the dose, these types of behaviors can go away or remit. So now that we covered the basics on some of the cognitive and non-motor behavior symptoms, I want to move on and talk a little bit about some other strategies and pointers here. So number two, I think it's important to know that the field of Parkinson's is continually evolving. And I just want to share a couple examples with you on that. So I mentioned before this premotor or prodromal period when we were talking about depression and anxiety. And really, we too get smarter and smarter as we learn about the science, neuroscience of Parkinson's and our treatment. So what we've now recognized is these non-motor symptoms may occur years or decades before the motor symptoms. And this has redefined how we think about Parkinson's and how we can think about disease-modifying strategies and times to intervene such that we can aim to have drugs that address very early symptoms or perhaps alter the course of Parkinson's. This has led to new definitions, just to highlight this here, with research criteria for prodromal Parkinson's and rethinking how we define Parkinson's, which opens up our windows of opportunity for thinking about disease-modifying strategies. We've also come to realize that many of these neuropsychiatric symptoms that I'm talking about are part of Parkinson's or can be part of Parkinson's. And I like this slide from a number of years ago. It focuses on publications, but it just shows you how the tremendous increase over the decades of research has focused on these cognitive and behavioral symptoms here. And that really, these are part of Parkinson's, which goes well beyond motor disorder. And then lastly, just to keep up with the times, this is hot off the press as we think about redefining Parkinson's, a publication that just came out a week or two ago, redefining the faces and images of Parkinson's to broaden it across a greater diversity of the population. Okay, so my point number 3 is to recognize your individuality, often represented by how snowflakes, one is not like another. And we know that in Parkinson's, each person is unique in his or her journey. Not everyone will experience the same symptoms. We know that people have differences in their progression, and this may be resulting from a whole variety of factors: their genetics, their environment, their personality, their medical history, and many other facets. And this goes for the cognitive and behavioral symptoms that I've been speaking about as well. So there's this saying, which I do think remains true, is that if you've met one person with Parkinson's, you've met one person with Parkinson's. So your individuality may play a role in the symptoms that you may experience, as well as perhaps the treatments that are best for you. We know in a couple examples here that cognitive and behavioral symptoms can be associated with different clinical motor symptoms. So there's some literature suggesting, although not exclusive, that people who have more difficulty with their postural stability or their balance and more gait rather than tremor may experience more cognitive or behavioral symptoms. We've also learned that there might even be gender differences, such that female patients or women living with Parkinson's may exhibit greater mood and apathy symptoms. Genetics too may play a role, and there are several genetic mutations listed below in alpha-synuclein, glucocerebrosidase or GBA, that may be linked to greater cognitive or neuropsychiatric symptoms. And then ApoE4 has been a little bit conflicting in the literature, but it represents a susceptibility factor with the E4 alleles in Alzheimer's, and it may also play a role in cognitive symptoms in Parkinson's, although that may still be controversial or conflicting. Here you can see in the diagram, which is taken from literature not related to Parkinson's, but related to cognitive changes in the general population. When we think about what we individually bring to the table, there may be individual risk factors and individual protective factors. And some of these are modifiable. Some of these we may have some control over, like our diet, whether or not we drink alcohol or smoke or have diabetes, how much physical and cognitive activity we do. So there may be modifiable risk factors that we individually can work on to help alleviate or ideally prevent some of these cognitive and behavioral symptoms. So my next point is to focus on building your care team. And this is something that I could probably talk a ton about, but it's really important in Parkinson's because it can affect many dimensions, not only physically, but with the cognitive and behavioral symptoms we're talking about, and the other ones that I'm not going to include in my lecture, like constipation or bladder dysfunction, vision changes, that it really takes an integrated approach with a team of providers. So not one person can address all of this alone, and it really speaks to having a team approach. This team approach gives a deeper dive, a deeper investigation into the motor and non-motor symptoms, and helps people living with Parkinson's explore the treatment options from many different perspectives, both medication, surgical, non-pharmacological, and even others. It helps provide objective and data-driven information that we can use to inform our clinical decision-making and helps people manage and assess their symptoms over time. So there are a number of studies that show that there's great benefits for teamwork for patients and their care partners too, in order to address all these different elements, as well as even the psychosocial elements of how this affects people living with Parkinson's, their relationships, work, hobbies, and others. And I will say, as someone who practices in an interdisciplinary care team setting, there are great benefits for us as healthcare providers to learn from our colleagues and be able to tackle issues from multiple different perspectives. So my next point is to take a multifaceted approach to management. And going through all the treatment regimens and ideas would take a whole nother talk unto itself. So I just want to provide some considerations and pointers for cognitive and behavioral issues in particular. So it's very helpful and important to have objective assessments at baseline and to follow these over time. We do a lot of this on the motor front. So we'll do finger tapping and other walking tasks, and we often do those at every visit. It's helpful to have a check-in, even once a year or perhaps more frequently, on how someone's objective cognitive and mood symptoms are doing. And there are a number of ways that we can do this, either in the clinic or working with neuropsychology, working with our speech language pathologists to assess cognition. If people are having problems in these areas, it's also important to exclude other causes. So are there medical syndromes or complications that are contributing to a decline in thinking or to psychosis? Someone having an infection, a urinary tract infection that might have triggered the acute onset of hallucinations. We need to review medications for both Parkinson's and non-Parkinson's reasons, because sometimes these can lend themselves to confusion or hallucinations or psychosis. Those might be pain medicines or bladder dysfunction medicines. It's important to think about management strategies, and I'll talk a little bit about medications and non-pharmacologic strategies, and again, to have this multifaceted approach. Whenever we talk about cognition and behavior and Parkinson's, we should also address day-to-day activities, whether that's work, driving, safety, and the home environment. And in that interdisciplinary or multidisciplinary care team, to address adjustments and the psychosocial impact of these changes. So we want to broaden the care team for the person with Parkinson's and their care partner across the management of these cognitive and behavioral symptoms. Just go back. Okay, I just wanted to go back to this slide to talk a little bit about medication management. And this could be a whole course unto itself. So I listed all the symptoms that we talked about before and a few of the treatments that we have that are FDA approved and others that we might consider. So for dementia and Parkinson's, there's one medicine that's FDA approved, and that's called rivastigmine or Exelon, and it's a cholinesterase inhibitor as a type of medicine. And that has been studied in trials to help with cognition and thinking. For mild cognitive impairment, there have been a number of studies, but to date, there hasn't been a medicine that has come through with meeting the clinical trial outcomes that were planned. But we think about medications and we think about strategies to enhance cognition, including working with cognitive activities, occupational therapy, speech therapy, brain games, and exercise, which we'll talk about. For depression, there have been a number of randomized controlled trials looking at antidepressants and Parkinson's. Most of these medicines are really drawn from the general population. So there's not a specific antidepressant that is linked to Parkinson's treatment per se. But we do know these medicines, which are often selective serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors, the SSRIs and SNRIs, can be highly effective in treating depression. Depression is a very treatable symptom. We often work with our psychiatry team and geriatric psychiatrists, primary care doctors to manage these depression symptoms. Similarly, these SSRI and SNRI medications often work well in anxiety. So we know that we can help manage anxiety with medications. We may also think of specific medicines that are called anxiolytics. Sometimes they can have side effects that can affect balance or thinking. So we want to use some of these very cautiously. And again, working on situational anxieties to help alleviate or work around specific situations that might be triggering anxiety. For psychosis, we very often start by looking at the Parkinson's medication regimen and its adjustments. So we might need to lower doses of dopaminergic medication, reduce them, or perhaps stop certain medicines that we are using to treat the motor symptoms. And this is taking an approach that balances the motor and the mental function. In the US, pimavanserin or Nuplazid is FDA approved for the treatment of Parkinson's-related psychosis. There are other medications that have been used off-label and studied to help treat psychosis as well, including quetiapine and clozapine. As I mentioned before, for impulse control disorders, one of the first things that we would do would be to counsel a patient about these medications and potential side effects, but really to reduce or withdraw that particular medicine, such as a dopamine agonist, such as pramipexole or ropinirole, for example. And often by reducing and potentially discontinuing that medicine, we can stop those impulse control behaviors. But this can take a team approach and working with a psychiatrist for other strategies as well. Apathy is one of our trickier behavioral symptoms to treat, and it often takes a combination of thinking about how it can be helped by different dopaminergic medicines, the antidepressants, and even the cognitive enhancing medicines like rivastigmine that I mentioned for cognitive changes. Specifically in depression, there has been a lot of work done looking at a specific technique called cognitive behavioral therapy. Here you can see two studies that illustrate the benefit of cognitive behavioral therapy, which is geared towards reframing our thoughts and our behaviors and actions. So working on kind of deconstructing why we might have these negative thoughts and reframing them into something that's more constructive. This has now been looked at using a telephone-based approach. And in both of these studies, the cognitive behavioral therapy improved scores on depression rating scales. And in the telephone group, it outperformed what is abbreviated as TAU, or treatment as usual, on all depression, anxiety, and quality of life measures. This is often done by a psychologist, a specific counselor with training as well, but can be very effective in combination or solo to medications for depression. So turning to exercise. Exercise is one of those areas that we know helps with so much in Parkinson's. So it certainly helps with motor function, and as you'll see, many of these non-motor symptoms. So I just put up here some of the guidelines from the CDC regarding what people should be doing for regular exercise. So that's 150 minutes per week of moderate intensity exercise, done as listed below. So a minimum of moderate intensity aerobic plus 2 or more days of strengthening, or perhaps a high intensity workout and 2 or more days of strengthening, or an equivalent mix of moderate and high and 2 or more days of strengthening. And again, talk with your doctor. If anyone has any medical issues, talk with your doctor about getting started on your exercise regimen. But what we also know is that exercise can help motor function, but it can help cognition as well. This is one example of a study that I was involved in, looking at 51 people with Parkinson's who didn't have any significant cognitive issues at the time of the study, and they tried 2 different types of physical exercise. So they had a progressive resistance exercise training protocol, or a more general kind of what's called modified fitness count exercise protocol. And what they found is both groups in exercise had improved cognitive performance in some of those domains that I mentioned earlier in the talk. So exercise is good for the brain. Exercise is also good for people's mood. And this is a compilation of a number of different studies of different sizes. So as you can see here, some of them had very small numbers of participants, all the way up to 231, looking at depression, finding in most of these studies that exercise, physical exercise, had an impact on reducing depression. More recently, there have been some studies looking at yoga versus, in this case, stretching and resistance training exercises on anxiety and depression in a clinical trial. And so in this randomized clinical trial, or RCT, for 8 weeks, the group looked at mindfulness yoga versus stretching and resistance training in 138 people with mild to moderate Parkinson's. And they administered a clinical rating scale looking at anxiety and depression. What they found was the therapies were both effective and safe. But interestingly, yoga performed better than the stretching and resistance training on its effects on anxiety and depression, perceived hardship, and health-related quality of life. The next point I wanted to make is geared to maximize function and quality of life. And so it's helpful and important to take a look at your everyday activities, whether that involves self-care, leisure, things in the house, or work, and think about how cognitive and mood symptoms might play a role. We can strategize, so we can work with people to help plan their day, help them expend energy so they can do the things that they want to do, and balance out some of these symptoms, whether they're cognitive or apathy or fatigue. Often this is where the role of an occupational therapist might come in. And interestingly, not as many people in the world, as you can see by the United Kingdom survey, the Dutch survey, and United States data, are often referred to occupational therapists. So somewhere between 10 to 25% of people. But occupational therapists, a number of studies support this, can help support better functioning of people with Parkinson's in their day-to-day activities, planning them, coming up with strategies, keeping track of them, and looking at fatigue and energy conservative strategies. There are also a number of tips and tricks. There's a great role and a growing role for technology in utilizing ways to remember medicines, or pay your bills, or plan your day. But don't forget the simple. So often just keeping a list or a Post-it note can be just as good as a fancy gizmo or gadget. But there's no shortage of gadgets and apps to help with medication reminders, adaptive equipment, augmentative technology and communication to even help with speech volume or speech recordings. And now we're moving into the world of wearable sensors where we can actually have real-time monitoring, such as for falls and alert systems, and perhaps also for these cognitive and behavioral symptoms. So again, just a reminder to be creative, and there are many solutions that can play a role. All right, we're coming towards the end here. The 8th point is that it takes 2 or more people to tango. And this is a plug for looking at relationships and more, particularly when we're talking about cognitive and behavioral issues. So it's essential to recognize the potential for caregiver stress, worry about these symptoms, or living with someone who is experiencing these symptoms. This is more common with advanced Parkinson's, with greater motor symptoms, and with greater presence of neuropsychiatric symptoms, such as dementia or psychosis, or many of the other ones that I mentioned. We need to address these caregiver challenges and stress across all stages of Parkinson's. We need to consider how having these symptoms and having Parkinson's might affect changes in roles, what people were doing in a relationship, and adjusting to a new normal. Parkinson's can affect the whole family, not only the spouse and the significant other, but other people, friends, and family. And so with someone experiencing cognitive changes or apathy, we want to work to help maximize, getting out and being engaged or being social. It's helpful to plan ahead and to maintain healthy coping skills. And again, not being afraid to ask for help. There are many resources and ways to connect, particularly with people who are the care partners joining us today. They include the Parkinson's team. Again, this may also include a social worker, psychologist, counselor, spiritual personnel as well. There are numerous support groups, community networks, and Parkinson's foundations who can help with these cognitive and behavioral symptoms. A few particular strategies for coping to help take control. Again, these can be high-tech or low-tech, but making checklists for specific tasks. So remembering medications or meals or exercise, when to do it, and put it on the calendar. Using Post-it notes as reminders around your house. Keeping assistive devices like a cane or walker within your line of vision so you remember to use it when you go to walk. Often people, if they have cognitive changes, can have trouble with accessing or retrieving the information, but it might be there, it might take longer. So often giving cues can be helpful, or given choices rather than open-ended questions. There are many different memory strategies that can be employed. Again, asking for help. We call those human reminders. Having a routine is very important, particularly if there can be cognitive changes, apathy, sleep disturbances. Getting enough sleep can often help too with many of these mood symptoms. And again, being kind to yourself and practicing gratitude can help with some of the mood symptoms as well. And empowering people to address and tackle these situations. So if you thought for the caregivers and the audience, particularly in light of cognitive and behavioral symptoms, is to take time for yourself and to be kind to yourself too. To build in breaks in your day, and to create your own support system too. Find ways to express your feelings, whether that's in a support group, to friends, therapist, in a journal. That can be often helpful, particularly if someone's experiencing these cognitive and behavioral changes. Sometimes, such as in psychosis or in other behavioral symptoms, it's important to recognize that it's sometimes the disease talking, not your loved one. And again, education and support, and cherishing those moments and practicing gratitude. Just a plug to participate in research, because this helps us advance our field and have more drugs and therapeutics to help treat the symptoms and give more options to people. Many current research studies can be found on clinicaltrials.gov. And in terms of research, there can be an important role for people with Parkinson's to participate. This is a growing area of engagement, and we really need to, work on this together, whether it's for motor symptoms or cognitive and behavioral symptoms. And this slide just illustrates a couple ways that people with Parkinson's and their caregivers have been involved in research, from setting the agenda to help developing research questions, working on study design, and more. And this really is a way of medicine that is changing and becoming more of a participatory medicine, where people are involved in the actual process and are partners with the clinicians and researchers. There are many benefits to this, including promoting growth and well-being that have been looked at in a variety of different literature fashions, but really having patients engaged in research is critical to our pipeline. Lastly, to keep up hope. So we know that, in just to pull one area here, this is from a very recent paper that looked at drugs under study in active Parkinson's drug trials this year, from January to close to current. These are many different drugs that are in the pipeline of study, whether they're disease-modifying therapies or symptomatic therapies. And on this talk on cognition and behavior, which often are non-dopaminergic, so they're related to different brain chemicals, acetylcholine, serotonin, norepinephrine, rather than the dopaminergic motor symptoms. Here you can see in green, here in the bottom part, all the different compounds that are being studied for these types of symptoms. And about 30 to 40% are in phase 2 and phase 3 trials. And lastly, no matter where someone is in their journey with Parkinson's, whether it's early stages or middle or more later stages, there is something that I think we can always offer, whether it's medications or therapies, counseling, palliative care, for all these non-motor symptoms and cognitive and behavioral symptoms. With that education and awareness, dialogue with your care team, there's something that we can offer. And so with that, we put together a slide that illustrates many of these cognitive and behavioral symptoms. And I will thank you for your attention. Appreciate your attending this talk. And this is just a glimpse of where I work here at Shirley Ryan Ability Lab and Northwestern in Chicago. Thank you so much. Thank you all for attending the APDA Midwest Congress, both yesterday and today, and hope this has been very educational for you. It's been my pleasure to be part of this. So we have a number of questions that were submitted, and thank you all for these really terrific questions. So I'll read them and answer them. And one of the first questions regards the non-motor fluctuations that I mentioned, for which anxiety and sometimes also depression can be part of. And so this person asked, if I am experiencing anxiety when my medications are wearing off, what might I need to do? And I think there are a couple thoughts on this, and these could be brought to this person's medical care team for further discussion. But sometimes it's helpful to keep a diary to understand when symptoms are occurring in relationship to their timing with the Parkinson's medicines. We often think about doing this for motor features or motor complications like dyskinesia and wearing off, but it can also be helpful for anxiety or mood symptoms with that cycle. And for some, that means if people are experiencing wearing off mood changes like anxiety or depression, we might want to adjust the frequency of the Parkinson's medicine or the dose of that medicine, or have something that perhaps is more smoother acting that gives a longer duration. So those are a couple different strategies. Often that might need to be combined with medications too to treat the anxiety or depression as well, and some of the non-pharmacologic strategies I mentioned in my talk. So thank you for that great question. Another question had to do with the medications that can be associated with some of these non-motor behaviors, like hallucinations or impulse control behaviors. Now, we know that to some degree, medications that increase dopamine or enhance dopaminergic transmission in the brain also act on some of that reward and pleasure circuitry that I mentioned. So on one hand, any medicine that has anything to do with increasing dopamine could have this as a potential side effect. However, what we also know is that certain dopamine receptors in the brain have different characteristics. And some of these receptors are found in areas of the brain that are very involved in cognition, thinking, emotional response, and they're part of our cortical limbic circuitry. And in some cases, the dopamine agonists may favorably interact with these types of receptors, often called the D2 and D3 dopamine receptors. So there may be a potential higher likelihood with some of those medicines. But again, it's a much more complex question, so it's not as simple as just one medicine versus another, but it's really putting the whole picture together with someone's level of cognition, their abilities, their medical history, psychiatric history, addiction history, and so forth. So thank you for that important question. Another question came up to talk about different strategies for mild cognitive impairment. And this is certainly something I could talk about for a long time, near and dear to my work and my career. And there's a growing emerging studies in terms of cognitive therapy. So there's not a uniform or standard or evidence-based program for cognitive therapy, but this is a growing area. And I think some of these trials that we see engage in cognitive rehabilitation therapies, learning different strategies, perhaps for tasks that involve attention or recall or memory. They may include cognitive exercises or brain games. Many of these you may see on various computer programs or apps on one's phone or iPad. And I think what we're trying to learn is how useful they are and is there carryover. So if we train our brains to be much better at one task, does it make a difference on all those other tasks, and how does it play out in the real world? This is an area often that speech-language pathologists and occupational therapists can be helpful in helping someone with these therapies. Okay. Another question had to do with support and resources for spouses who may be living with someone who has compulsive behaviors. And now there may be a great role for support groups and other resources geared towards Parkinson's symptoms. So Parkinson's support groups certainly could play a role in this area. Often we'll work with psychiatrists or psychologists who may play a role, and then other behavioral groups. So even drawing from people's experience in addiction or other conditions that are not Parkinson's, but may be helpful for these sorts of impulsive and impulse control behaviors. Okay, so another question that came up, and thank you all for sending these questions, they're terrific, has to do with cognitive problems, and could it even mimic other conditions such as attention deficit disorder? And because some of the areas we see that can be affected in cognition and Parkinson's may relate to attention. So paying attention, concentrating on a task, keeping multiple items in one's head as we're trying to do other things like working memory or executive function that I spoke about with planning and organizing and multitasking, there can be quite an overlap in terms of these types of symptoms. What they share in common, in part, has to do with the different regions of the brain that are affected, that are highly involved in allowing us to pay attention and concentrate, or having trouble with that. And that's part of the frontal area of the brain, particularly the prefrontal area. So often cognitive symptoms can mimic some of these other attentional disorders, which can occur in a variety of neurologic conditions. So we might need to tease that out. And sometimes objective testing might be helpful, working with neuropsychologists might be helpful, and so forth. Great. Again, talking about some of the cognitive problems, and this question has to do with, if someone has cognitive problems, can they last for days or weeks, and then the person might snap back into a better state, if you will? And there is something called fluctuations. So we often think about this in terms of motor function, but there are also fluctuations in cognition that can occur. And these may be periods of fluctuations in levels of attention or arousal or alertness. And for some, when people might be experiencing more significant cognitive impairment, they may be coupled with these fluctuations. These fluctuations are also found in conditions that fall under the umbrella of Lewy body dementia. That includes Parkinson's disease dementia, and then also a related condition called dementia with Lewy bodies, where fluctuations can be prominent. And this may present as someone, being very clear at times, and then perhaps their thinking is not as sharp, or maybe a little bit more muddled, for a day here, or a couple days, or weeks, and then people may go back to their more lucid state. I will say that if someone is experiencing acute changes in their cognition, or acute changes such as psychosis or hallucinations, it's often important to investigate if there's something else going on. And that's where looking at infections, like urinary tract infections, new medications, adjustments even in the Parkinson's medicine doses, could they have been changed? And is that a contributor to this acute onset or this fluctuation? Okay, so some of the, great. So one question has to do with non-medication interventions, which often play an essential role in the therapeutic management for cognitive and non-motor behavioral symptoms, either alone or in conjunction with medications. And so this question has to do with psychosis, wondering if there are any non-medication interventions. And there are some. So there are some things that have been helpful for people experiencing psychosis. We know that for many, hallucinations occur in the visual system, or visual hallucinations, and they might be more present when it's darker out, or in the evening hours, or when there's not as great contrast between light and dark. So for some, having a night light in the hallway, or a night light that turns on automatically in the hallway, could be helpful and could help illuminate the path, or reduce shadows or changes in perception. So that's one particular strategy. There have been other coping strategies that have been studied and published, including people who have taken to art to actually depict their hallucinations, whether it's watercolor or drawing or painting. For some, that can be very therapeutic. And then, of course, even anecdotally, I've had people make up a story about them and have a name to go with the person who might be visiting, who's not really there. And so there are all sorts of creative coping strategies that can help people navigate this. Okay. There are other situations. So this is a question about agitation. And for this question, this person asks about episodes of extreme agitation and what to do about that. And so for some people, particularly in more advanced disease or with greater dementia symptoms, people might also experience agitation. And this is one of those areas where trying to figure out what might be the cause might be helpful. So sometimes if it's hard for people to express themselves verbally, they may have other behavior manifestations that come out to try to convey what's going on. So is someone in pain? Do they need to go to the bathroom? Is there something that's bothering them? So trying to get a sense of that as best as possible. To understand if the agitation might be linked to certain times of the day, there's a phenomenon called sundowning, such as when the sun goes down, people may have some behavioral changes or confusion. And there are other medications that might be used to reduce agitation. Again, working with someone's physician, neurologist, psychiatrist can be helpful in that regard. One question someone asked about the use of electroconvulsive therapy or ECT to treat extreme depression and Parkinson's. And thank you for that question. I did not talk about other modalities outside of medication and psychotherapy or cognitive behavior therapy for depression. But there has been, there may be a role for what we call neuromodulation or ECT for depression that's refractory to medications, such as with transcranial magnetic stimulation or TMS. And then for refractory cases, ECT. And that again would be a conversation with the psychiatrist and the psychiatric team. ECT has been shown in some older studies in its treatment of depression, but there are some side effects and cautions to be wary of that might affect temporary confusion and behavior. So again, under medical guidance. Another question that came up that seemed to be a popular question here had to do with recommendations for off periods. And I think thinking about off periods, we want to think about, are they the motor symptoms or the non-motor symptoms that are part of the off period? And some of those strategies globally are trying to smooth out the day. So smooth out the Parkinson's regimen, whether that's with different doses or shorter intervals, reduced frequency, longer acting agents that cover the day, or even surgical interventions. So I think there are a number of strategies that can be helpful for off periods. So with that, I'd like to close and thank you so much for your attention and joining us here today.
Hi everyone, we are going to do some breathing exercises and singing exercises and then sing a song to help us practice using our lungs and our voice. So first we're going to start off with some breathing exercises. What we will do is I'll start my metronome and then we are going to say Z quickly, 2 Z's for every click that you hear. So let me get my metronome out so that everyone can hear. And so we'll breathe out for 4, breathe in for 4, and then 2 Z's for every click that you hear. So ready, breathe out, and breathe in. Okay. We'll do that again. And I let the timer go on for about a minute just so when you run out of air, it's not going to be the same time as when I run out of air. So just to give you that extra time, give you something to work towards. All right, so we'll do that again. Just go until you run out of breath. Don't pass out or anything, but do try to challenge yourself. So we'll breathe out, and I'll count to 4. Ready, and breathe in. All right, very nice work, everyone. Okay, our next exercise we're going to do is a familiar one for most of you that are singing with us in the choir. It's I know, I know, I know, I know. This helps with breath control. This helps with the muscles in your throat, especially that epiglottis that we've talked about before in these videos that is so important for swallowing. It also helps with pitch range, which helps in just everyday speech. You don't want to have a voice where you just you speak everything at one pitch level or one note, I should say. All right, so you're gonna sing, I know, I know, I know, I know. And when you'll release your arms, you'll sing, I know, I know, I know, I know. So we'll do that one more time, starting at our starting scale, our pitch. So I know, I know, I know, I know. I know, I know, I know, I know. I know, I know, I know, I know. I know, I know, I know, I know.
Hello, everyone. Thank you so much for joining us. My name is Tao Z. I'm an associate professor in neurology. I'm the director of Wound Disorder Clinic and the DBS program, and also the director of IR Center of APDA at the University of Chicago Medicine. Today, I'm going to share with you my talk on deeper brain stimulation in Parkinson's disease, optimal patient selection, limitations, and new developments. This is my disclosure. There's no conflict of interest to the content I'm going to talk today. The education objectives today will cover indication of DBS, which is about what DBS can help, and what target should we choose if so, and also what's the limitation of DBS, what DBS cannot help, and the potential issues, and what's the new developments we have had so far to make DBS better in terms of better symptomatic control, less side effect or less complications, etc. So what's a DBS? DBS, deeper brain stimulation, stimulating a specific area in the deeper brain. Those areas we also call the nucleus are very important to coordinate and control movement. Specifically, there are 3 targets approved by FDA. The first one was VIM, ventral intermediate nucleus, for treating medication refractory tremor. The tremor can be from essential tremor or Parkinsonian tremor since 1997. The second one is STN, subthalamic nucleus, and another one is a GPI, globus pallidus internal, for treating Parkinson's disease since 2002. And the GPI is also approved for treating dystonia in 2003. And we also know that STN can also be used to treat a certain dystonia in Parkinson's disease. This is a location, as you can see on the right side of the slide. This is VIM, this is STN, and this is the GPI. Today, we're going to focus STN and GPI for Parkinson's disease. So this is the sagittal view. As you can see, this is the VIM in the thalamus. This is the STN below the thalamus, and this is the GPI. So when we talk about stimulating the nucleus, in fact, we not only just the nucleus, we also stimulated the fibers connected to nucleus, connected to the widespread area of the brain, including the important sensory motor cortex and other structures. In this way, only in this way, it sounds like possible when you stimulate such a small area, you can have a huge clinical benefit. Then the question is, how do we put the DBS electrode? First of all, we have to identify the target by anatomic target, electrophysiologic target, and then eventually we have to verify that the stimulating to the target works. Works mean that it can control the symptom Parkinson's disease, Parkinsonian syndrome or Parkinsonism, and also without any side effect or complications. So specifically, we have to get a brain MRI first and also head CT with a stereotactic frame, and then we merge them together and then overlapped by anatomic atlas, which will help us to identify the anatomic target. And then we send a needle size or smaller probe down toward that target. In the meantime, we also recorded a signature, a neuronal discharge to make sure that the anatomic target also fits the physiological target. And once we get there, then we replace the probe with the stimulator device, the electrode, and then we stimulated the patient, make sure that all the symptoms we want to control can be get control immediately, including the tremor. You can immediately see the tremor stop in the operating room. And other symptoms like rigidity and the bradykinesia can also be improved when you're testing it. And that's not enough. We also have to make sure that there's no side effect or complication when you stimulate those targets. what if we encounter some issues? For example, you feel the symptom controlled, but in the meantime, you also feel numbness, tingling, or pulling sensation, or vision problem, or abnormal sweating, etc. Then based on this symptom, we know where we should adjust, can move around the target by 1 to 2 millimeter and to get rid of this complications. We will not finalize the target until we get a maximal therapeutic benefit and therapeutic window with no side effects with the normal stimulating parameters. Once we finalize the placement of the electrode, then we also need to put the battery, also called the impulse generate, IPG, under the skin of the anterior chest below the collarbone area, and then connect this battery to the electrode. And then by programming this battery, we can send a signal to the brain and control the various movement or coordinated abnormal movement in Parkinson patients. The parameter we send to control there, including the pulse width, the voltage, and the stimulating frequency. So why we need a DBS for patients with Parkinson's disease? Parkinson's disease patient, their symptom Parkinsonism, particularly the cardinal symptom of bradykinesia, resting tremor, and the rigidity, usually respond very well to dopaminergic medication, particularly over the first 5-7 years. But as time goes, the patient develops a motor complication with rapid weaning off. The medication feels like lasts shorter in duration, and then with quick returning of the Parkinsonia symptom. And also, when the medication is on, the patient develops dyskinesia, which is an excessive, involuntary dancing-like a movement. If you watch TV, Michael J. Fox, you know what it's like. They can be on your neck, arm, or leg, or trunk, or throughout the body, which initially can be managed by medication adjustment, but as time goes, it becomes more and more difficult to be well controlled. Then you need to consider deeper brain stimulation. And also, tremor may not always respond well to medication, to current available dopaminergic medication, even some anticholinergic medication. But some patients somehow never respond to any medication. In those cases, you also need to consider DBS. So then who is the candidate? What's the DBS criteria? In general, they should have a good response to levodopa because roughly the amount of, the extent of the response to the medication determine the extent of response to the deeper brain stimulation. If the patient still has good response to levodopa, particularly bradykinesia, rigidity, and tremor, you don't have to have a response to the dopamine medication. You still can be a candidate for DBS. And then if you also develop a symptom like a motor complication, like we call the rapid weaning off, as just mentioned, or dyskinesia, which is excessive involuntary dancing like a movement, then you can consider DBS. Also, we would like the patient has Parkinson duration for more than 4 years to increase the confidence level of diagnostic certainty, because some patients can mimic Parkinson disease, but may not be Parkinson disease. They can present with Parkinsonism, but in fact, it may not be Parkinson disease. But so far, only Parkinson disease respond well to DBS. So the patient also should not have significant cognitive impairment, such as dementia, or should not have uncontrolled psychiatric symptoms, such as uncontrolled depression or psychosis. Also, they should not have significant focal lesions in the brain to prevent from implanting electrodes. They should also have reasonable good health condition in heart, lung, and the general systemic healthy to tolerate the surgery. And also the patient and the family should have a reasonable expectation for DBS with good family support for follow-up programming after surgery. So then what's the evidence on the beneficial effects of DBS? This is one of the early paper published in 2001 in New England Journal of Medicine. It shows you that if we target the STN after the DBS follow-up in 6 months, as you can see that the on period without dyskinesia significantly improved from 27 to 74, and the off period from baseline 49 reduced to 19% in 6 months. Similar improvement can also be seen from GPI, suggesting that STN GPI DBS reduced the off period and improved the on period without dyskinesia in Parkinson patient. DBS is also better than best medical therapy for PD. As you can see, a bunch of study there across more than 10 years period. And Dr. Andrew Williams in UK did a meta-analysis, and the data shows here suggesting that in selected patients, basically based on the criteria we just mentioned, the patient always favors surgical treatment compared to best medical therapy. And particularly, as we mentioned, that the trauma patient, even the trauma does not respond to medication, they still respond to DBS very well. And that's also the case, as you can see here. And according to this study, there's no significant difference between STN and GPI in terms of trauma control after DBS. Then the question you might have is which target is better, STN or GPI? This is a study compare these two targets. Due to the limited time, I will not go to detail, but the conclusion is that there's no difference in motor function or self-reported function between these two groups. Patients undergoing STN stimulation required a lower dose of a dopaminergic medication than those undergoing GPI stimulation. Roughly, after STN DBS, patient can have reduced the dopamine medication by 30 to 50%. But GPI, usually you don't see much change, or you have less than 20% of the reduction if you put all the different study paper together. And cognitive function can be slightly worse in patients receive STN DBS in terms of visual motor function of processing speed. But depression also worsened after STN, but improved after GPI stimulation. I think the motor symptom, they are similar between these two targets, but non-motor symptom in terms of depression probably slightly favor GPI based on the study. But medication reduction is more seen in STN. That's very important, when you select a target for individual patient, depends what their problem is and what you would expect to target to improve. For example, if the patient present Parkinson's disease with good response to medication, but medication dose is too high with medication side effect, hallucination, blood pressure drop, etc., then STN probably is a good target, because after the DBS, you can reduce the medication and reduce this medication-induced side effect. Just as an example. So the question you might have now is, how early should I start a DBS? Usually in older days, we pick up a patient with motor fluctuation. On average, it's about like 4 to 5 years after the onset of motor fluctuation of dyskinesia and rapid weaning off. At that time, it was also usually about 11 to 13 years after onset of Parkinson's disease. I mean, this is a study we call the early STIM study, published in February 2013 in Europe. It shows that if you pick up a patient within 2 years onset of motor fluctuation, at that time it's about 7 to 8 years after the onset of the disease, DBS compared to medical therapy significantly improve the quality of life. So they conclude that early stimulation can be used in patients with PD and early motor complication because, as you can see here, the quality of life is better. Then another question you might ask is, what if we put a DBS for this patient without motor fluctuation? We call it early stimulation. A study by David Trust group, published paper 2018 and 2020, this year in neurology, shows that early stimulation in their pilot trial without motor fluctuation in the 2-year and 5-year follow-up can slow rest tremor progression and reduce medication needed. As you can see here, this is a 2-year study result. The red bar stands for the medication therapy group. As time goes, the tremor gradually progressively getting worse. And also they found that the tremor not only just total score, but also spread to the other side initially without tremor, while the DBS group, you don't see significant change over the 2-year period, suggesting that probably DBS could also be beneficial in very early study, even without motor complications. But you know, this is still pilot trial, more multi-site trial is ongoing now. So then DBS sounds great, very effective in control cardinal symptom of Parkinson's disease, bradykinesia, rigidity, and tremor, and the motor fluctuation and bradykinesia. However, DBS also has its limitations. The benefit on axial symptom, such as swallowing function, freezing, gait, and balance, is not very effective, particularly in the long term, can even be worse based on some meta-analysis data. And also there's no direct effect on non-motor symptoms such as cognitive function, autonomic function, etc. So this is a well-cited meta-regression study of long-term effect of DBS on balance and the gait and the cardinal symptom. On the left, A and C is medication off state. As you can see that with a 5-year follow-up period, both STN and GPS, DBS patients doing well on cardinal symptom, bradykinesia, rigidity, and the resting tremor, but their axial symptom, balance and gait, gradually getting less effective. Okay, almost close to the baseline at year 5. But when medication on states, as you can see that the cardinal symptoms still respond to it, but become less and less beneficial. But the gait and the balance group, once past the 2 years, they can even getting worse, particularly on the STN group. But GPI probably will not get worse until 5 years after. So it means that, you know, the axial symptom can gradually lose the benefit to the DBS as time goes, particularly on medication on states. And the study was also supported by a bunch of other summary study as well. I will not talk detail here, but that's the overall impression. So now why is it so difficult to treat the axial symptom? Most likely because axial symptom is controlled by non-dopaminergic mechanism, cholinergic, as suggested by some study. And so far, all our medication targeted dopaminergic medications. So then how we deal with this axial symptoms, what's new or relatively new? There was one study published in 2008 by a French group proposed that low frequency stimulation It's around 60 hertz issues. Some people also use 80, but most people use 60 hertz, compared to high frequency stimulation, which is the usual stimulating frequency, around 130, anywhere between 120 to 180. They found the low frequency stimulation improved the freezing gait in those patients who has DBS about 2 to 5 years at off medication states. And our study also supported this one and found that even in some acute stimulating patients, the frequency still play a role. And then we move on to the randomized study, and then we found not only low frequency stimulation controlled the freezing gait in those people with those gait refractory to high frequency stimulation. We also found that this low frequency stimulation in this population can improve or reduce the aspiration, even though about 15% of the patient, they found that the tremor is slightly getting worsening under low frequency stimulation. But aspiration is more an issue, freezing gait is more an issue, because these two symptoms are the most important symptom associated with high morbidity and mortality in patients with Parkinson's disease. And so far, there's no good treatment for it. So we also found that it has a long-term benefit as well, particularly for the freezing gait, even though as time goes, the beneficial effect is gradually reduced. So then who should try low frequency stimulation? You know, high frequency stimulation should still be the mainstream treatment. We did a review paper and summarized all this published data by Aasef Shaikh as well, and we found that low frequency stimulation should be tried in patients with freezing gait refractory to routine high frequency stimulation. But trauma can be worse in about 9 to 15% of patients under low frequency stimulation. So then your question is, what about another important symptom, swallowing function? We recently did a systemic review on the effect of DBS on swallowing function. And we found that ST and DBS on the usual stimulation frequency can have beneficial effect, no effect, or detrimental effect. While low frequency can have beneficial effect on those patients with freezing gait, as mentioned. GPI DBS could have a beneficial effect or no effect, but no detrimental effect on swallowing function in PD. So the fact that DBS on the swallowing function is pretty much consistent with the meta-analysis data from the gait and balance, because this is not a surprise, even though this is the first systematic review on the swallowing issues, because they both belong to axial symptom. So then why the low frequency could help in some patients? It's probably because it stimulates another target, the PPN, peduncular pontonucleus, which is very close to the STN, as you can see here. And also there are anatomic and physiological connection between these two targets based on the report by other study group. So overall conclusion, routine DBS high frequency stimulation works very well on motor complications, waiving off dyskinesia and medication refractory trauma in PD patients, working on majority of the patients. And low frequency can be tried only in this patient presented with axial symptom refractory to usual high frequency stimulation. And hand trauma can be worse in about 9 to 15% of patients under low frequency stimulation. And the DBS can also be tried in patients with early motor fracturation. As you see, the early stim show the improvement in quality of life, and possibly even in those trauma-dominant patients without motor complication, even though that study, the largest study, is still ongoing. But so far, there's no direct effect on non-motor symptoms so far, such as cognitive dementia issues. Of course, if some of the symptoms, non-motor symptoms such as hallucination or blood pressure drop, secondary to the medication overdose, then DBS targeted STN can indirectly improve the symptom. So other new or relatively new developments. One of them is the stimulation of post-ceramic area PSA, including the CZI, cortisone, inserted fibers for better control of tumor. Because we mainly focus on the FDA approved the Sarma VIM and STN GPR, but there's another one called post-STN area, including CZI. Let's take a amplified look at this area. This is called the post-subceramic area, mainly contain the ZI, zona inserta, and also prelimnistic radiation area. Basically, it's about 2 millimeters below the VIM. If you look at the axial plane of the brain, it's the posterior to the subceramic nucleus and lateral to the red nucleus. So why this is important? Because this is an area where the fibers from basal ganglia and fibers from cerebellum, both area is involved in the generation and the modulation of trauma. They merged in that small area. That's why stimulating this area, stimulating the fiber, become very efficient. You apply a little energy, can have a big beneficial effect with possibly less side effect. So this is based on the review paper on the effect of DBS in this area, and also supported by a recent randomized blinded evaluation compared the DBS in that area versus the best medical therapy in patients with PD, and they found that the trauma control is much better in DBS group by more than 90%. So this target could be a potential a new one for better control trauma, possibly with less side effect based on the review. And another exciting thing is the directional DBS. When targets are so small, as I just showed you, precision and direction are crucial. This is the STN target. As you can see, this is a traditional electrode, the DBS electrode. Usually they contain 4 contacts. Okay? You can pick up either one to stimulate. And because only one target on one level, when you apply the stimulation, you stimulate the area you want, and also on vertebrae, you may also stimulate the area you don't want. That can cause side effect. And also that would waste the energy because you stimulate large area, even though some areas are unnecessary for you to stimulate. And this is a direct stimulation. As you can see, on one level, you can have 3 contacts. You can choose one of them, or you can choose 2 of them. You can choose 3 of them. You can apply different portion of energy. You can put more on here or more on the other side, depends the clinical needs. And also you can stimulate the several contacts at the same time, depends the clinical needs. So that gives you much precision stimulation, and also potentially reduce the unwanted stimulation side effect. And also because it's a precision stimulation, the energy is less, so you save the energy. Even though nowadays energy probably is less an issue because you have a rechargeable battery as well. That's part of another development. So another new development still ongoing is adaptive or closed loop DBS. The future is closed and adaptive to individual DBS patient. It basically is individual as needed stimulation based on the electrophysiological biomarker or wearable sensor markers detected by the brain, and then the brain know when I should turn on the DBS, or which DBS, which part, which program, or should I just shut it off? For example, as I mentioned, that if a low frequency help the axial symptom freezing gait, and then when the patient walking, they can turn on the low frequency. And when the patient is sitting, the resting tremor become problem, and then usually the tremor respond better to high frequency stimulation. Then they can shut off the low frequency stimulation and turn on the high frequency stimulation when the patient is not walking, when the patient is sitting and resting. So, and this allowed to having a more precision or accurate stimulation is on needed basis, and also will reduce the side effect. Again, also in the energy saving. But this one is still ongoing, but I think the future is closed and adaptive. So let me quickly share with you some real video from clinical from OR. So this is a patient, Parkinson patient with a resting tremor. This is a video recorded in OR. As you can see, the patient developed resting tremor. Now we hit the sweet spot by direction DBS, the tremor immediately stopped, right? Now when we stop the DBS, the tremor immediately return, as you can see here. It shows that DBS is very effective in tremor control and other Parkinson symptoms we turn on. And this is a patient developer of freezing gait on the usual 130 hertz high frequency stimulation. This stimulation improves all other symptoms, particularly cardinal Parkinsonism and dyskinesia. However, the patient, as you can see, has freezing gait, particularly when she turns around. Feels like the feet is stuck, glued to the floor, as you can see, right? And now we turn to low frequency stimulation of 60 hertz. That also improves the speech and the swallow. And as you can see, his gait become much better. Even when she make a turn, there's no freezing. So this is a patient swallowing study. As you can see that at the routine 130 hertz, she has a little bit of aspiration. This is a patient with a significant freezing gait. And then we switch to 60 hertz. You can see that you can see there's no aspiration. The tiny bit here is left over from the previous study, as you can see here. It's not the aspiration. So the overall conclusion as a DBS is very effective under routine condition and control selective motor symptoms in various stages of Parkinson patients. Mainly it's motor fluctuation, dyskinesia, medication refractory tremor, and in some patients, medication overdose with side effect, and also not only effective in patient with later complication, but also in patient with early complication. And some study also show that even patient with that complication can be also beneficial, particularly tremor, even though that's still part of the data. And also new development provide more precise stimulation like a directional DBS and energy saving with a better control of symptom and better quality of life. And the future will expect a personalized in-need stimulation. That's pretty much all I would like to share with you this morning. I hope it is helpful. I guess you might have lots of questions to ask. I'm more than happy to entertain and discuss in a moment. Just bye for now. I'll get back to you in minutes. Thank you again very much, and including thanks to my DBS team. Hello, everyone. I'm so excited to be here with you all this morning again. Thank you so much for taking time joining us, and also thank APDA organized such a wonderful event. I hope the talk is informative. But I'm sure you will have a lot of questions as well. So this is a special Q&A session. That's why we're here. I'm here. Please feel free to ask as many questions you might have, and I'm more than happy to answer. Let's get started. The first question from Anonymous, does DBS become less effective over time, or will it just continue to be calibrated? So this is a great question. A lot of patients asking the same question. DBS is very effective, particularly for the cardinal symptom, the core symptom, a motor symptom of the Parkinsonism, including bradykinesia, which is slowness in movement, resting tremor, and stiffness, which is more specific as a rigidity. This cardinal symptom continue to be responsive to the DBS based on the meta-status analysis data, systemic review studies, and also large studies, larger population in larger center. So far, a good response has been reported over 10 years or longer follow-up period. So the second question, is it possible to wait too long to get a DBS? I think yes and no. I think it's if you wait too long, then because DBS is mainly improve your quality of life, will not alter the disease progression. So in that sense, whether you study early or not, will not study the disease, because it's not a disease modifier therapy. But on the other hand, DBS can dramatically improve the quality of life. So earlier, as long as you fit the criteria, should be recommended. And also, if you wait too long, then comorbidity could become more of an issue. Because you need to have a good general health condition to tolerate the surgery, even though it's not that big a surgery, but still, waiting too long is not good for the safety of the surgery and complication, and also, most importantly, the quality of life. So particularly, given the current evidence is just covered, we have early stim study showing that early stim at early stage, less than 2 years, when you develop a motor fluctuation and the dyskinesia, can have significantly improved quality of life. So I think that's another reason. We have evidence, we have rationale to support that once you fit criteria, you should be considered taking this procedure. But eventually, it's also a discussion between you and your mood disorder, because it's also certain cases you need it to be individualized. And another question from Anonymous is, if I don't have a good response to levodopa, what are my options? Yeah, this is a good question. There's a couple of possibilities there. One possibility is whether you really have a diagnosis of idiopathic Parkinson disease, because so far Parkinson disease will respond to the DBS well, but not other Parkinson mimics. For example, if you Parkinson plus disorder, such as a progressive supranuclear palsy or multisystem atrophy, at the early stage of disease, they may look like a Parkinson's disease, but in fact, they're not. So that's the reason when we talk about the criteria, we also talk about a greater than 4-year disease course, because that would increase your level of diagnostic confidence. So that's one possibility. Another thing is maybe, it's a really advanced stage, the response to the medication may not be great, or maybe other comorbidity limit the full motor assessment. So you need a visit a movement disorder specialist to do a thorough evaluation. But here I have to point out that if your trauma does not respond to medication, still the trauma is a very good indication to get a DBS, because DBS would have a good therapeutic effect in controlling trauma, regardless of whether your trauma respond current medication or not. That's an exception. So what is involved with DBS maintenance? Maintenance is not really much, because once the electrode implant to your brain, it's like a permanent placement there. The only thing is that the battery can be drained, and for that reason, usually the battery lasts about 3 to 5 years, depends how much energy used in a programming. And nowadays we have also this rechargeable battery, so they can last a very long time, 9 years, 15 years, or even 20 years. So it's less an issue. The other thing is that some patients after surgery, they find itching on the surgical side, but then try not to scratch it. If you scratch it, you can cause a skin abrasion and then cause skin infection. So other than that, if you suspect any other abnormal sensation or any question about DBS, feel free to contact your movement disorder specialist to get a detailed consultation advice. Another question from Anonymous: if I'm having problem with cognition, would I still be a good candidate for DBS? Good question. In general, we would like to have we would like a patient to have a good cognitive status for multiple reasons. One of the major reasons is some studies suggest that the cognitive function in certain cognitive domain, such as visual mode, processing speed, verbal fluency, etc., can be affected to a certain degree. More so by doing STN, DBS, and GPI, even though other study later on, including meta-analysis data, found that the deficit from that is minimal, and also the difference between two target, the discrepancy in terms of cognitive function is also minimal. So in general, we would like to have a good or reasonable cognitive function, and also that's another thing for the quality of care as well. So another question is also from Anonymous. I had my first DBS in June 2014 and my second one in September 2015. My question is, how long should I expect the first DBS to last? I think this is the very common concern from patients. They got a staged DBS at two different sites at two different times. And as I also covered in first answer to the first question, DBS for the cardinal symptom has long-term benefit. The report paper can show the more than 10 years so far. Although, so 1 year difference will not show significant difference in terms of benefit. Still, long-term there to enjoy. And even though the axial symptom, the speech swallow balance, can be an issue, particularly as time goes. Why is that? Because it's probably involves some non-dopaminergic mechanism as well, such as cholinergic, norepinephrine, etc., as we covered in our talk. Another question, what percentage of your DBS patients experience no decrease in levodopa intake? I had a DBS 2.5 years ago. Okay, this is a good question. A lot of people think that the purpose of DBS is to reduce the medication. That's not true. The purpose of DBS is to improve the quality of care no matter what. Okay, yeah. So I think the quality care is a major thing. So we matter. Where's the question? Oh, okay, time flies. I hope I can answer more questions, but we only have 15 minutes. Feel free to contact after the session anytime. We're available here. And again, thank you so much for joining us, and I hope you continue to enjoy the rest of the program. Take care. Bye-bye.
Hello, everybody. My name is Rebecca Gilbert. I'm Chief Scientific Officer at APDA, and today I will be discussing medical marijuana and Parkinson's disease. This is a topic that many people really want to know a lot of information about, and there isn't a lot of information out there. And so I'd like to provide today the connections between medical marijuana and Parkinson's disease and the information that we may find helpful to be able to think about this product and how it may help people with Parkinson's disease. So before we begin, just want to be clear that this presentation, and really any presentation at this conference, is not an endorsement of any treatment. This is solely designed to educate you and to be able to have a discussion, an educated discussion with your neurologist or movement disorder physician, because all treatment decisions are going to be a collaboration between you and your neurologist or movement disorder physician. So let's begin with the basics about marijuana and medical marijuana. So medical marijuana is derived from a group of plants known as cannabis. And cannabis is a genus of plants that, when ingested, can exert numerous different effects on the brain and the body. And this is because cannabis contains hundreds of different chemicals. We also know that cannabis, when ingested, can cause a high, which means that it causes a euphoric feeling in the body. And this has led to the potential for abuse of this particular plant. But it turns out that anecdotally, over the years, users of cannabis found that it would help certain medical problems, such as chronic pain, for example. And this has led to efforts to create medical marijuana, which is purified chemicals from the cannabis plant to be used at specific doses in order to produce a specific medical result. And primarily, there are two chemicals within the cannabis plant that are purified for this purpose, and these are THC and CBD. THC and CBD are shown here on this slide. THC is a psychoactive chemical, so it is part of the chemicals responsible for that high feeling. CBD, however, is not psychoactive and is not responsible for that high. Medical marijuana typically consists of purified combinations of THC and CBD in different ratios. So one could have only CBD, sometimes only THC, but often a combination of the two. And another variable in how medical marijuana is dispensed is that it can be dispensed in various forms. So there are liquids, pills, nasal sprays, powders, all sorts of ways of ingestion of these different chemicals. So how do THC and CBD work, and why do they have effects on the body? So it turns out that THC and CBD mimic particular chemicals that are found within our bodies, and they bind to receptors that are found in our bodies, and these receptors are known as endocannabinoid receptors. The natural chemicals that bind the endocannabinoid receptors and the receptors together compose this system called the endocannabinoid system, or the ECS. The ECS in our bodies regulates many functions, including mood, pain, memory, and appetite. And so I have a little schematic down at the bottom of this slide where in the natural state, we have ECS receptors in our bodies and in our brains, and we have our natural ligand, our natural chemical within our bodies, and they bind, and together they form biological responses. If one has ingested either THC or CBD, this mimic can interact with the receptor as well and cause similar reactions. And so that is what our cannabis chemicals are doing. Now, it is unfortunate that the system in our bodies was named the endocannabinoid system, because it implies that somehow this natural system had cannabis in mind when it was formed, and of course that isn't the case. this is a natural system that has nothing to do with cannabis, but it turns out that cannabis and some products of cannabis can interact with this natural system in our bodies. Now, I want to emphasize, and I want this to be a real important take-home message of this talk, and that is that there are many medications used in Western medicine that are derived from plants. So that is not at all a unique property of medical marijuana. And each of the medications that have been derived from plants and are now used in our medicines were studied in clinical trials and approved for use by the FDA based on those clinical trial results. So being a plant does not get you out of this process by which a medicine is approved for use. The reason we have this process, this clinical trial process, is because we want to know if the medication really works, and we want to know if there are side effects that are problematic or there are adverse effects of these medicines that we need to know about. And we will only get that information through properly designed clinical trials. And so medical marijuana should be treated like any other medication and undergo the clinical trial process. What we know anecdotally and from people who take it, that medical marijuana can of course have side effects, much like any other medication. Again, medical marijuana being treated like any other medication, we have to be very conscious of the potential side effects. And the side effects are not that surprising. They could be sleepiness, confusion, psychosis even, difficulty concentrating, apathy or a lack of interest in things, mood changes, gait imbalance, all things that are problematic for everyone and specifically for people with Parkinson's. And other potential side effects, nausea, hypotension or low blood pressure, diarrhea, dry mouth. Now, this of course doesn't mean that everyone who takes these products will get all these side effects, but something to consider in the process of understanding medical marijuana. Other things to know is that the effects of THC and CBD may be prolonged in those with impaired liver or kidney function, something else to be wary of. And what we always need to highlight is that as people age, they are more prone to side effects in general for this particular medication and other medications. And so we have to be even more careful about side effect profile in people as they age. Another thing to remember is that medical marijuana can interact with other medications. So if someone is on other medications for other medical problems, we want to consider that as well. Having said all that, medical marijuana is used in Western medicine for specific indications because the clinical trials do support the use of medical marijuana for these diagnoses, certain types of childhood epilepsy syndromes, chronic pain, and chemotherapy-induced nausea. And so clinical trials have been done for these particular entities. So there's use of medical marijuana for these entities. There is not the same level of evidence for Parkinson's disease, and certainly more clinical trials are needed. One could hypothesize that medical marijuana may be helpful for certain elements of Parkinson's symptoms, for example, tremor or dyskinesias, possibly stiffness or rigidity, when the body is too tense, too shaky, moving too much. Medical marijuana may be able to calm that down. Potentially insomnia, inability to go to sleep. Medical marijuana may be helpful for that. Dystonia or twisting of an arm or a leg that can be painful, pain in general, weight loss. These are all symptoms that are problematic in Parkinson's disease and may find some relief in medical marijuana. However, each of these symptoms will need to be evaluated with a clinical trial. In addition, as we've mentioned before, THC and CBD can be dispensed via different delivery systems, as we mentioned, in different doses and at different ratios. And we do not know the optimal delivery system dose or ratio for any of these symptoms. So there is a lot of information that's missing. I'll receive questions frequently. What is the best dose of CBD for my pain? We don't know. What is the best dose of THC, CBD for my tremor? We don't know. We don't know if it's effective. We don't know what the specific type that should be given. And so there's a lot of information missing, and we need clinical trials to evaluate all these permutations. Now, why is it so difficult to get information about medical marijuana? And that's, of course, because federally, medical marijuana is illegal. And that is, of course, a major obstacle to doing research on medical marijuana, because you cannot get money to do federal money to do the clinical trials that are necessary. And so the Parkinson's community is advocating to ease federal restrictions on medical marijuana research. This is very important to move the field forward. And there are many bills that have been introduced already in Congress, and there are various levels of stages of going through the bill process. And hopefully we will make some headway on that front to ease the ability to get information about medical marijuana. Despite the fact that federally medical marijuana is illegal, many states have made it legal. Now this dichotomy is a very interesting legal situation, and it's obviously a work in progress. Here is a map of the United States, and it's color-coded based on where the different states are in their legalization of marijuana. The green states, marijuana is fully legal, which means it is legal recreationally and medically. In red, it's prohibited completely, recreationally and medically. The blue states, however, keep forbidden medical marijuana recreationally, but do allow it on some level medically. Now, there is a tremendous amount of variability between state to state on what is allowed, even within all the states that are blue. For example, there are some states in blue that only allow CBD formulations of medical marijuana, and some states that allow the combination THC and CBD. This is important because there are some maps that you might see that differentiate between the states that only allow CBD from the states that allow both THC and CBD, and they may be color coded differently. So this map includes any medical marijuana at all is colored blue. Within those blue states, as I mentioned, the laws governing medical marijuana vary significantly. Most require some sort of certification for use by a physician, and many require registration with the state. Some require issuance of a medical marijuana ID card. Another difference between states is whether they list Parkinson's disease as a qualifying diagnosis to obtain medical marijuana. Some do, some don't. Some list chronic disease as a large category of disease that may allow you to obtain medical marijuana, and Parkinson's disease may fit under that broad category of chronic disease. Let's turn to the actual data that's available that looks at medical marijuana for PD. I've mentioned a number of times that we do not have a lot of data, but we do have some. So let's look at the data that's available and see what we have to make any decisions or make our understanding of medical marijuana and PD more complete. Now, as you probably know, there are different types of clinical trials. Two big categories of clinical trials are here on this slide: survey-based trials and open-label trials. A survey-based trial would be a type of trial where a large group of people are given a list of questions, perhaps about their medical marijuana experience, what they use it for, what type of medical marijuana they use, and what the results are. And those results are tallied. Now, survey-based trials are certainly very interesting. They give us some insight into what people are doing in their homes. It gives us some insight into whether what they're doing they perceive as helpful, and it gives us some information about what to study in the future. But what it doesn't do is allow us to really obtain information that we can generalize to everyone, because there is a lot of variability in what people will report. What people report is not validated, and so it is not data that can really be used to justify acceptance of a medicine for everyone. An open label trial is a bit more rigorous. In that situation, the medicine is actually given to a patient by the researcher. But in an open label trial, patients know that they're receiving the medicine. There's no placebo or group that does not receive the medicine. And so a person cannot really fully evaluate whether the medicine is helpful for them because they understand that they've received the medicine, and that can influence their the results of how they feel when they take the medicine. There have been 5 clinical trials of Parkinson's disease and medical marijuana that were conducted in the most rigorous fashion, and those are placebo-controlled, so some of the participants get the treatment, some do not. Randomized, which means the participants are randomly assigned to either receive the treatment or are in the placebo group and don't receive the treatment. And double-blinded, which means that neither the participant nor the research staff know who is in the treatment group and who is not. And so let's look at the trials that have been done. So here, I'm going to show you a bunch of tables. I do not expect anyone to really read every word. I'm just going to give you a general overview of the trials that we have available in our literature. The first table looks at the patient survey type trials, and there have been 5 over the years. And as you can see, the sample size, that's the third column, varies quite significantly to very small to very large to 454 patients. In general, these patient surveys, again, look at patients who've taken medical marijuana on their own and what results they've had in their symptoms. And for example, the first trial here in 2004, this patient survey shows that these patients did report improvement in their motor symptoms of PD. The second trial showed that over 50% showed benefits in their mood and sleep. A smaller percentage showed benefits in their motor symptoms. The third showed 77% reported benefits in their pain. The fourth, also improvement in their non-motor symptoms and reduction of their prescribed medication. And the last, decreased complaints of falling, stiffness and tremor, decrease in pain, sleep, improvement of mood. In general, patients who take medical marijuana on their own and then report back what it does for them, in general, feel like it is helpful. And again, this is important information. We want to capture it, but it is certainly not enough information for us to then say, this works for everyone. The next 2 tables are open label trials. And again, these are trials in which the medication is given to a group of patients and then the results are tallied. And there is no placebo group. The patients all are very aware that they've received the medicine, and the researchers are aware that they've received the medicine. And in general, this type of trial where there isn't a placebo group is not considered a rigorous trial because patients who are aware that they receive a medicine tend to do better. And this has been established in trial after trial. And so we are a little bit wary of jumping from an open label trial to saying this is an efficacious medicine. But of course, it is interesting to capture and to report that these results have been received. Again, these trials are very small. These trials are much smaller than the survey trials. Here we have between 5 and 22 patients that were tested, and various results are logged. And again, overall, there is a trend to improvement. There are some trials that did not show improvement in the results that they expected, but most of the open label trials do show some level of improvement from the medication received. And let's look at our most rigorous trials, our randomized placebo-controlled trials. And there were 5, as I mentioned. And in general, these trials have some mixed results. Well, what we must note here is that our sample size, again, the number of people that receive the medication is very small. It ranges between 4 and 24, so very small groups. And so these are not the numbers that are really enough for FDA, for example, to come and say this is a medication that is effective for everyone. Just as comparison, medication trials that do lead to approval of medication have hundreds or thousands of patients in them. So we're quite far from the numbers that are really required for approval of a medication, but it's definitely a start. And these 5 trials looked at various results, various outcomes. And again, as I mentioned, there is a bit of variety in what the different trials showed. The first trial showed a reduction in levodopa-induced dyskinesia severity and duration. The second trial, however, did not show an improvement. The third trial did not show an improvement. And the last two do show improvements. The first, the one in 2014, showed improvements in quality of life with 300 milligrams of CBD. And the last one was an interesting trial where they gave 300 milligrams of CBD powder and looked at anxiety and tremor in a simulated public speaking test, and showed that in a randomized placebo-controlled way, there was improvement in the group that received the CBD. And so, to summarize, patient survey and open label studies tend to demonstrate that medical marijuana has benefits in PD, but this type of data is not sufficient to approve a medication for use. Results of the 5 randomized controlled trials showed mixed results. They were small, but definitely some were suggestive that some forms of medical marijuana are helpful for some symptoms, and definitely intriguing, and pushes us to really need to know more and to perform larger clinical trials to get that information. So the bottom line, more work needs to be done to determine if medical marijuana is useful, what it is useful for, and which formulation is best. In the meantime, based on what we know already, there is enough to have a discussion with your healthcare provider to discuss whether this is something that you may want to pursue, even if not all the information that we want is available. And please discuss this and, of course, all your medical decisions with your physician. And now, of course, we are looking toward the future to see what other clinical trials are available. Potentially, people listening to this talk may be interested in joining a clinical trial to further our knowledge about medical marijuana and Parkinson's. So there are 3 that are listed in clinicaltrials.gov right now. Clinicaltrials.gov is a list, pretty comprehensive list of all the clinical trials that are available throughout the world. And we have 3 here that are looking at this impact of medical marijuana on Parkinson's. The first is looking at cannabis oil for pain in Parkinson's disease. The second, looking at tolerability and efficacy of CBD on motor symptoms in Parkinson's. And the third is looking at nabilone. Nabilone is a synthesized cannabinoid, so it's not derived from the plant, but it is made in the lab to mimic a cannabinoid. And it's looking at that chemical for non-motor symptoms in Parkinson's disease. And so this is a start, a few more trials to help us gather the information we need to make informed decisions about our patients. I have listed here all the references of all the different clinical trials that I mentioned. And on that note, I want to thank everybody for listening. And I want to once again encourage everybody to educate yourself, to take this information to your doctor, and to make informed decisions about your medical care. Thank you so much for listening today.
Hi, everyone. Thank you so much for listening to the talk on medical marijuana and Parkinson's. And now I'm going to try to answer some of the questions that have been coming in. The first question from Anonymous is there any evidence that marijuana interacts negatively with levodopa? To my knowledge, there is no specific evidence that the two interact poorly. So I do not think that's going to end up being a major problem in our giving of medical marijuana to people with Parkinson's. The next question from Anonymous is there a difference between CBD oils and lotions and something you would take orally? I am not aware of the ability of CBD to be absorbed through the skin. There may be a literature on this, and I just don't know, so I do not want to comment on how a CBD is absorbed through the skin. My guess would be that CBD taken orally would be a more powerful way of getting CBD into the system than using the oils. So my guess is that the oils would not be really what we're talking about here, that we're really talking about either intranasally or orally would be the way to get the CBD in. But again, not something I'm 100% sure about. So thank you for that question. The next question, what are the next steps in researching PD and marijuana? And back to really getting that data, really designing clinical trials that help us answer exactly what type of medical marijuana is needed, dosing, addressing issues of dosing, addressing issues of method of delivery, which delivery system, there are all sorts of different formulations, and also addressing symptoms. So you need a clinical trial that's designed and sort of selecting from those lists, what type, how much, method of delivery, and then what the outcome that you're looking at. So it really is, it's impossible to say, let's look at medical marijuana and Parkinson's. Medical marijuana is too big a group of different types of compounds. And Parkinson's is too big a group of symptoms. You really need to pick, really hone in on what exactly you're looking at. And the successful trials have done just that. They've taken a very specific type of CBD, for example, a very specific outcome, and tried to really study one thing, something that kind of makes sense for the Parkinson's population. So those are the kind of trials that we're looking at to help us figure out this quagmire, really. We have a question from Susan. This is a really great question. How would the use of medical marijuana affect a Parkinson's patient that also suffers with cognitive problems and dementia? So here we get into a bit of trouble because, as we know, every medication can have side effects. And people who are elderly, people who have neurologic disease, people who have dementia, are all more at risk for side effects in general than other people. And so we would expect that side effects from medical marijuana would follow that pattern as well. And so it would be much more fraught to be considering medical marijuana for somebody who already has cognitive problems and dementia than somebody who may be looking for something for a more specific symptom, maybe tremor or insomnia, but doesn't have a whole array of other issues. And so I would be very wary of going down that path or even thinking about medical marijuana for somebody who has a more complex picture with the cognitive piece as well. We have a question from Anonymous. How can we, people with Parkinson's and caregivers, help move marijuana research forward? So that's a great question. Short of finding a trial to participate in, and I did at the end of the talk mention 3. What I did not mention is that they're in all parts of the world. One is in Toronto, one is in Austria, I think one is in Colorado. So if you don't happen to live in one of those areas, it probably will be difficult to join a trial. You can always be talking with your physician about potentially new trials that are being publicized and need participants. So keeping your ears out for opportunities to participate in clinical trial research is, of course, one way to do it. Another way is to contact your Congress people, your representatives in Congress, the Senate and the House of Representatives, and to say, there's multiple ways of engaging with your elected officials, send emails and all sorts of things. It's very easy these days, and say, I want there to be federal lifting of federal restrictions on medical marijuana research, and making your voice heard in that way. And that will help us move the field forward because there'll be federal money that can support these medical marijuana trials. Anonymous also asked a question. It seems that CBD can treat a lot of ailments. How can one drug help so many different things? Fantastic question. And that, of course, is really the crux of this issue. Medical marijuana has gotten this aura around it that it is the panacea for every ailment. And of course, it's not. It's a plant. And the plant didn't figure out how to solve humanities problems. And so I agree with you 100%. It is absolutely impossible that CBD is going to be the savior that some think it is. So what we're trying to do here is precisely attack exactly what you're saying, meaning take that general notion in society that medical marijuana is a cure-all and break it down and say we have to study each aspect individually and figure out whether or not it is true that CBD could help that particular symptom. So, for example, sleep problems, tremor, etc., and break it down and study it in a clinical trial and look at the outcomes and figure out whether or not CBD helps that particular thing. And so, yes, you do need to be very rigorous in this type of research. And your point is very, very well taken, and I think that's a great point to emphasize to anyone listening today. There's a question about getting the list of references, which I'm assuming we should be able to do, but we do need to know who you are to be able to get to send you those references. So perhaps I will talk to our technical back end and see if we can figure out how to get you the list of references that you can download yourself. Anonymous also asked, does having used marijuana typically exclude you from being able to participate in clinical trials in general? I do not think that would be an issue at all. I have never seen use of medical marijuana as an exclusion criteria for a clinical trial. Of course, every clinical trial is going to be different, but I would not think that would exclude you from many clinical trials. I have a note here from one of the conference organizers that if you send an email to APDA STL, so that would be APDA St. Louis, APDA STL at apdaparkinson.org, and request a copy of the slides, you can get a copy and you'll be able to see those references. Okay, we have another great question from Anonymous. If I have severe problems with my gait, should I avoid medical marijuana? So again, this is very similar to the question about cognition. People who have worsened problems with their thinking, would that be a reason to avoid medical marijuana? And I was, hesitant in saying that somebody with cognitive problems should be considering this because it does add a huge layer of complexity. Very similar to somebody with a gait disorder because, again, medical marijuana and all medicines can have side effects. One of the side effects can be imbalance or general unsteadiness. And so if there are these additional, more complex features of the Parkinson's disease, then we would be more wary about the side effects as well. So yes, so somebody who has a more complex picture would be more give it a little bit more thought about whether this is a road to go down or not. So I agree with all those people sending in comments that side effect profile does have to be strongly considered. What I should say, just to clarify the comment about how can CBD, sort of be the panacea and help everything. What we do think is that medical marijuana is going to be a drug, or is a drug that sort of calms down nerves. And so anything where the nerves are revved up, so there's a lot of tremor, or there's a lot of insomnia and you can't sleep, or there's a lot of twisting of muscles and pain. There's nerves that are overexcited. Medical marijuana potentially could sort of ease that and take the burden off of those super excited nerves. So that's where the list that CBD may help, or medical marijuana in general may help, comes from. It's sort of all the aspects of Parkinson's that are where the nerves are too active. So one could imagine that CBD or medical marijuana in general helps those symptoms in which the nerves are too revved up. Not so much that it's a panacea of everything, but it may be a panacea of overactive nerves. That may be a way to think about it. So on that note, I am being asked to wrap up our Q&A session. I want to thank everybody again for listening, for participating in our Q&A, and participating in this Midwest Congress in general. And now you're going to be returned back to the main event. So thanks so much again for listening.
Hello, I'm Scott Hunter, Vice President of Sales and Marketing at Amneal Pharmaceuticals. We are very excited to be part of this incredible event, and we are confident it will provide a great spirit of community, education, and inspiration for people living with Parkinson's, their care partners, and families. At Amneal, our team comes to work every day with all of you in our minds and hearts. We are passionate and dedicated to our work in Parkinson's disease. Again, we are so glad to partner with you today in this event and wish you the very best.
And this concludes the third annual Midwest Parkinson's Congress. Hello, I'm Roger Halleen, the president of the American Parkinson's Disease Association's Midwest Chapter. And on behalf of everybody at the American Parkinson's Disease Association, the Greater St. Louis Chapter, and the Midwest Chapter, I would like to thank you for joining us today. And it has been a true honor to bring you this educational event to the Parkinson's community. Every day at the APDA, we provide support and education and research to help everyone impacted by Parkinson's live life to the fullest. We are excited that we are able to share all of our wonderful, knowledgeable speakers with you today, and we hope that you have learned something new and feel that you have gained some knowledge that you can take away from this educational Congress. I would like to encourage you also to visit the APDA website and take advantage of all their educational material and other educational webinars on that site. However, this would not be possible without the support of our sponsors. And I would like to thank the sponsors at our champion sponsors, the James Addison Bates Foundation and the JCA Charitable Foundation. I would also like to thank our collaborator sponsors, Arcadia Pharmaceutical, Amneal, Emerson Hemrick Motors, and Kiwana Curran. I hope that during this Congress, you were able to visit their sponsors' resources booth to learn more about how they support Parkinson's and the Parkinson's community. Once again, thank you so much for joining us today, and we hope to see you again soon at our APDA Optimism Walk. Please check our website for more information on these walks. Thank you.